Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. We are the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very important, crucial, and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to humbly ask you to sit back and spare me part of your very precious time to share some tips with you. Welcome to part 38 of our Pharmacotherapy MCQ series. Our first question reads, AOL, a 67-year-old African-American female, presents to the endocrinology clinic at your hospital. She has a past medical history of hyperlipidemia and hypertension. She informs you of a 15-pound weight increase in her body weight over the past half a year as a result of her poor nutrition and bad habit of limited exercise. Currently, she has a BMI of 30 and her fasting plasma glucose concentration is 163 milligrams per deciliter. She has an A1C value of 6.8%. So my question to you is, which of the therapeutic plans listed below would suit AOL the most? Is it a diagnosis of type 2 diabetes mellitus and you'd recommend initiation of treatment with medication? Or do you diagnose her with pre-diabetes and encourage lifestyle changes? Or is it a diagnosis of type 1 diabetes mellitus and you recommend initiation of treatment with medication? Or would you opt to repeat blood work to make a diagnosis and obtain another glucose concentration on another day? Do you prefer to shelve the decision today? I'll give you 10 seconds to choose the correct answer. In my opinion, I would make a diagnosis of type 2 diabetes mellitus and initiate treatment with anti-hyperglycemic agents. Now, the American Diabetes Association Standards of Diabetic Care states that diagnosis of type 2 diabetes mellitus can be made from two abnormal results from the same sample. Now, this lady's FPG is equal to or above the 126 milligram per deciliter mark, and her A1C meets the conditions of being equal to or above 6.5. Now those are the two values among the two values that the ADA uses to diagnose type 2 diabetes mellitus. So they confirm a diagnosis of type 2 diabetes mellitus, in my opinion. Now, AOL has type 2 diabetes mellitus based on her age. Remember, she's above 45, so she can't have type 1 diabetes mellitus diagnosed. There are also other risks of type 2 diabetes mellitus in her case, which include hypertension. Remember, she's African American by ethnicity, and she acknowledged the fact that she lacks physical activity. Those are some of the risk factors. Now, it is appropriate to initiate pharmacologic treatment at the time of diagnosis. You don't have to wait for ages. Now, the diagnosis of prediabetes, which they are talking of in alternative B, is made with an FPG of 100 to 125 milligrams per deciliter, and in such cases the A1C should fall in the range of 5.7 to 6.5 not 6.5. 6.4 is the upper limit. Now, this patient doesn't meet the criteria for type 1 diabetes, as I said earlier, based on her age. Now, typically we know that type 1 diabetes mellitus presents in childhood and early adulthood. Remember, she's above 45. Now, criteria for diagnosis of type 2 diabetes mellitus include any two of the following. The FPG should be equal to or above 126 milligrams per deciliter, and or a 2-hour prandial glucose should be equal to or above the 200 milligram per deciliter mark, or the A1C should be equal to or above the 6.5% mark, or a random plasma glucose should be equal to or above the 200 milligram per deciliter mark in a patient with classic symptoms of hyperglycemia. Those are the few tips that I would use to quickly diagnose type 2 diabetes mellitus when a patient presents to an endocrinology clinic. Let's move to the next question, please. And it reads, HPB, an adult who is newly diagnosed with hypothyroidism, is initiated on levothyroxine. So my question to you is, when would you ideally recheck his TSH levels? Would it be after 15 days, 1 week, 90 days, or 45 days? I'll give you 10 seconds to choose the correct answer from the list of 4. I would recheck after 45 days. Remember, the correct answer there is about 6 weeks after initiation of thyroid replacement therapy. Now, that's due to the long half-life of levothyroxine, which is anywhere between 6 and 8 days. Now, checking TSH sooner, that is to say 15 or 7 days after initiation, wouldn't be reflective of the steady state for the TSH level. Thereby, it would lead to misinterpretation of the lab results by the clinician. That would cause such a clinician to inappropriately increase the levothyroxine dose. Now, waiting for 90 days, which is around 12 weeks, could result in the patient being overdosed or underdosed for too long. So 45 will be ideal, because by then the patient will have achieved a steady state, and you can easily make adjustments upwards or downwards dose wise. Let's move to the next question, please. The next question reads, after taking a thorough medical history and doing a thorough physical examination of a 58-year-old Hispanic female, a few days ago, you suspected she had a thyroid disorder. Her lab works revealed an undetectable TSH, elevated free T4 levels, and an elevated radioactive iodine uptake by her thyroid gland. So my question to you is, which of the disorders listed below could she be suffering from? Is it a case of Hashimoto's disease, Graves' disease? Is it a pituitary adenoma, or is this a case of thyroiditis? I'll give you 10 seconds to choose the correct answer. This, in my opinion, is a case of Graves' disease. TSH is a highly sensitive and specific test to determine overall primary thyroid function. Now, in the setting of normal hypothalamic pituitary thyroid axis, an elevated TSH signals an underproduction of thyroid hormones, which are T3 and T4, and thus a hypothyroid picture, that is to say, a case of Hashimoto's disease. However, a low or undetectable TSH level suggests overproduction of thyroid hormones and a subsequent hyperthyroid or thyrotoxicosis picture, which is evident in Graves' disease. However, in the setting of a pituitary adenoma, which is overproduction of TSH, the levels of the same TSH would be elevated, which would be stimulating the thyroid to produce additional T3 and T4. So in this setting, you would see an elevated TSH and free T4 as well. Now, Graves' disease and thyroiditis, if they are not in the recovery phase, both cause thyrotoxicosis, and they may cause similar TSH and free T4 results. Now, to further differentiate the two, we'll do what we call a radioactive iodine uptake test. I would order that test, and an increased thyroid function or activity will generally lead to uptake of iodine faster due to an increased thyroid function, and that would lead to an elevated radioactive iodine uptake test. And that can be the case in Graves' disease, for example. Now, the opposite would be true in decreased thyroid function, which would lead to a decreased or a decrease in radioactive uptake when undergoing that diagnostic procedure, and that would be evident in thyroiditis. So that's how I would differentiate B from D. So in this case, B would be our correct choice. Let's move to the next question, please. Our next question reads, after thoroughly doing a physical exam and interviewing a female patient suspected to have a thyroid disorder, several lab tests were ordered, and the results were as follows. She had a TSH of 48 million units per liter, free T4 levels of 5.4 nanograms per deciliter, with elevated radioactive iodine uptake by the thyroid gland. So my question to you is, which of the disorders listed below would most likely be her primary medical disorder? Is she suffering from Graves' disease, Hashimoto's disease? Is it a pituitary adenoma, or is this a case of thyroiditis? I'll give you 10 seconds to choose the correct answer. So it's a case of pituitary adenoma. Now the explanation to this and the previous question are almost the same. I'll just re-emphasize that TSH is a highly sensitive and specific test to determine overall thyroid function, and in the setting of a normally functioning hypothalamic, pituitary, and thyroid axis, an elevated TSH signals an underproduction of the thyroid hormones T3 and T4, and that corresponds to a hypothyroid picture that we see in Hashimoto's disease. However, low or undetectable TSH levels suggest overproduction of the same hormones and a subsequent hyperthyroid or thyrotoxicosis picture as evident in Graves' disease. However, in the setting of a pituitary adenoma, which is the overproduction of TSH, levels of TSH would be elevated, which would be stimulating thyroid to produce T3 and T4. So in that setting, we would see elevated TSH and free T4 and even T3 levels. Now, Graves' disease and thyroiditis, when they are not in their recovery phase, as I said earlier, can both be causes of thyroid toxicosis. They may cause similar picture with similar TSH and free T4 results. Now, to further differentiate the two, we would do what we call the radioactive iodine uptake test. We would order that test, and an increased thyroid function will generally increase the uptake or take up the radioactive iodine faster due to an increased thyroid function, and that would lead to elevated radioactive iodine uptake tests. That is evident in Graves' disease. Now, the opposite would be true in decreased thyroid function, which would lead to a decrease in radioactive iodine uptake when we carry out the same test. So because of those many ones, I would settle for a pituitary adenoma. Let's move to the next slide, please. A 69-year-old patient, male by gender, who happens to be a banker, presents to the endocrinology clinic with a past medical history of gout. He says he enjoys golfing and swimming. Now, the clinical team at the clinic asks you to recommend an appropriate A1C goal for this particular patient. He currently takes metformin and alogliptin, and he informs the team he is compliant with his regimen and he follows a diabetic-friendly diet. Currently, his A1C is 7.7%. So my question to you is, what would you recommend as an appropriate A1C goal for this patient? Would you recommend an A1C of less than 7.5%, 5.5%, 8.5%, or 8%? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for an A1C of less than 7.5%. Now, according to the American Diabetes Association standards for diabetic care for adults specifically, for the case of patients above 65 years of age who are otherwise healthy with few coexisting chronic illnesses and who have intact cognitive function and functional status, a goal of less than 7.5% would be considered appropriate. Now, an A1C of less than 8 is appropriate for adults above 65 years of age with complex or multiple coexisting chronic illnesses such as cancer, for example, congestive heart failure, incontinence, or even mild to moderate cognitive impairment, and our patient here, in my opinion, has good cognitive function given that he's able to work at the local bank, and from the text he doesn't have multiple coexisting chronic illnesses. So 8 and 8.5% are wrong. Now, an A1C of below 8.5 is appropriate for patients with very poor or complex health conditions, or those who have, for example, end-stage chronic illnesses such as stage 3 or stage 4 congestive heart failure, or even those who have oxygen-dependent lung diseases, or even patients with chronic kidney disease who require dialysis. So that's just a by the way. And all those many words make me biased towards setting or recommending an A1C less than 7.5. Let's move to the next slide, please. The next question reads, PRK, a 57-year-old male patient with type 2 diabetes mellitus and a history of stage 3 chronic kidney disease whose EGFR is 50 ml per minute, presents to your endocrinology clinic. He currently takes Januvia, which is sitagliptin, at a dose of 100 milligrams orally once a day, alongside metformin ER at a dose of 1000 milligrams after breakfast and after dinner. Some of his vitals include a systolic blood pressure of 137, diastolic 83, a BMI of 36, he's pretty obese, an A1C of 7.8, and a UACR of 330. His kidneys appear to be taking a hit. My question to you is, which of the recommendations below would have the most positive impact on Mr. BRK's clinical outcomes? Would it be the initiation of Trulicity, which is dulaglutide, subcutaneously administered at a dose of 0.75 milligrams weekly? Or would you opt for Invokana, canagliflozin, dosed at 100 milligrams orally once a day? Or would you introduce the sulfonylurea glimepiride, administered at a dose of 2 milligrams orally once a day? Or would you opt for semaglutide, Ozempic, or Ribelsus, administered at a dose of 3 milligrams orally once a day? I'll give you 10 seconds to choose the correct answer. I would settle for Invokana, canagliflozin, at a dose of 100 milligrams orally once daily. Now, Invokana is preferred because of the stage 3 chronic kidney disease in the absence of prior cardiovascular events or high atherosclerotic cardiovascular disease risks that I'm not seeing in this patient, and in his evidence of albuminuria. Remember, the UACR ratio, if I remember, was 330 milligrams per gram. The kidney appears to be taking a hit. Albuminuria is setting in. It is indicated to reduce the progression of chronic kidney disease according to outcomes of what we call the CREDENCE trial, CREDENCE trial, and that was done in patients with albuminuria with values above 300 milligrams per gram. Now, BRK could also benefit from the blood lowering and the weight loss and the A1C lowering effects of canagliflozin. It would be advantageous in his case. Remember, his BP is high, his A1C is still not at the optimal level. Now, dulaglutide and semaglutide administered orally could be options that could benefit this gentleman's obesity, but there is lack of evidence, in my opinion, for reduction of the CKD progression, and that could be crucial in his case. If we don't consider that, his kidneys will deteriorate further. Now, it would also require that we discontinue sitagliptin to start a GLP-1 antagonist, which is feasible, but there is no evidence of the use of combination. I would not use them together. Now, glimepiride, the sulfonylurea, could be an option if costs were a barrier, but it isn't recommended because of lack of evidence for additional benefit with chronic kidney disease and albuminuria, which appear to be a challenge in this gentleman's case according to his lab results. On the other hand, for cardiovascular disease, liraglutide, semaglutide injections, and canagliflozin and empagliflozin all have indications in secondary prevention of cardiovascular disease. Now, the American Diabetes Association guidelines recommend considering therapy based on cardiovascular disease risk or heart failure status or even chronic kidney disease status. So after metformin and lifestyle changes, those should be used or put into consideration when we are making a choice of what drugs to add on, just as a by the way. So let's move to the next slide, please. The question reads, MMZ, a 73-year-old Kenyan male, presents to the clinic at your hospital with a past medical history of atrial fibrillation that is not being currently treated with any medications. Very dangerous indeed. He informs the team that his heart medication was discontinued by his physician because it hurt his thyroid, in quotes, in his own words. Now, a rhythm controlling agent is indicated in this patient's case, according to your clinical team, though he adamantly refuses to take the medication that hurt his thyroid, in his own words, before. So my question to you is, which of the antiarrhythmic agents listed below can cause thyroid abnormalities and thus should not be prescribed for MMZ as per his request? Is it Sotalol, Amiodarone, Dronedarone, or flecainide? I'll give you 10 seconds to choose the correct answer. In my opinion, amiodarone it is. Now, amiodarone contains iodine within its structure, and it can cause hyperthyroidism, which is more prevalent in iodine deficient regions. It can also cause hypothyroidism, which is prevalent in the iodine sufficient regions. The effect of amiodarone on the thyroid gland occur due to both intrinsic drug effects, that is the blockade of the thyroid hormone entry into cells and inhibition of type 1 and type 2, what we call the 5-deiodinases, and iodine induced effects. That's just a by the way. Let's move to the next slide, please, which reads, select the correct statement or statements in relation to metformin use in all patients being treated for type 2 diabetes mellitus from the options listed below. So which one of them is true? Is it true that at higher doses metformin is associated with QT prolongation due to AV nodal effects? Or is it true that metformin shouldn't usually be started on patients with EGFR of 30 to 44 ml per minute per 1.73 meters squared? Or is it true that metformin increases gastric emptying, leading to food intake to cause constipation and weight gain? I'll repeat that again. It increases gastric emptying, leading to reduced food intake to cause constipation and weight gain. Or is it D? Metformin reduces hepatogluconeogenesis, which can improve fasting glucose measurements. I'll give you 10 seconds to choose the correct answer. So in my opinion, both answers B and D are correct. Now, most current recommendations suggest that metformin shouldn't be initiated or started if the current EGFR or creatinine clearance is already between 30 and 45 ml per minute, and to avoid its use completely if it is less than the 30 ml per minute mark. If patients have been on metformin without any problems, but their EGFR or the creatinine clearance falls between 30 and 45, then we should consider stopping metformin or reducing its dose by 50%. That will be at the discretion of the clinician or the endocrinologist. Now, metformin doesn't have any effect on cardiac conduction. So inhibition of the AV nodal cells usually causes a prolongation of the PR interval and not the QT interval. That was meant to confuse you. Now, class 3 antiarrhythmics like amiodarone, sotalol can cause QT prolongation. Just for your information. Metformin is known to affect gastric motility, and that can lead to loose stool and not constipation. So that makes answer C wrong. It doesn't usually cause weight gain, but it actually leads to weight loss. So that totally makes answer C wrong. And primary mechanism of action of metformin is to reduce hepatogluconeogenesis, that is the liver's production of glucose into the bloodstream, thereby contributing to the fasting glucose level. So that makes answer D correct. And metformin is linked with impairing of lactic acid clearance by the liver, especially in the context of poor renal perfusion. That's just by the way. And we know that the maximum daily metformin dose should be 2000 milligrams, just for your information. Let's move to the next slide, please. The next question reads, during the review of thyroid function test results for a patient examined at endocrinology a few days ago, you highly suspect he has primary hypothyroidism. So my question to you is, which of the lab results listed below would support your diagnosis for primary hypothyroidism? Would it be a low TSH and an elevated free T4? Would it be an elevated TSH and an elevated free T4? Or would it be an elevated TSH and a low free T4? Or would it be a low TSH and a low free T4? I'll give you 10 seconds to choose the correct answer. Correct answer would be an elevated TSH and a low free T4. Remember, primary hypothyroidism occurs when the thyroid gland isn't producing enough thyroid hormones, which are T3 and T4, but is being appropriately stimulated by TSH. Now, this results in elevated TSH levels because the thyroid pituitary hypothalamus axis senses there is not enough thyroid hormone in circulation due to a diminished negative feedback from the same hormones, that is T3 and T4, and a low free T3 and T4. Now, an elevated TSH and a free T4 can be seen in the presence of, for example, a pituitary adenoma. Then a low TSH and an elevated free T4 could be seen in thyrotoxicosis states, such as the Graves' disease, for example, and even the toxic multinodular goiter can have such a similar picture. And in both cases, the thyroid gland is being stimulated to produce thyroid hormones outside the normal hypothalamic pituitary thyroid axis, and that results in low endogenous TSH levels. Now, a low TSH and free T4 can be seen in central hypothyroidism, what we call secondary hypothyroidism, which can be caused by, for example, tumors or even idiopathic hypopituitarism, or even other disease states that decrease hypothalamus, or pituitary function. Those are just, by the way, to explain why this is a clear picture of elevated TSH and a low free T4. Let's move to the next slide, please. Our question reads, according to the International Consensus on Time in Range, which is abbreviated as TIR in endocrinology terms, what is the appropriate goal to achieve in most adult patients for TIR? Is it above 80%, above 90%, above 60%, or above 70%? With regard to the diabetics, I'll give you 10 seconds to choose the correct answer. So 70% is the correct answer. Now in type 1 and type 2 diabetes mellitus, the TIR goal is defined as above 70% or over 16 hours daily. Now this range is defined as 70 to 180 milligrams per deciliter. Now the goal is to increase TIR and to decrease the time below the range, which is abbreviated as TBR. Guidelines recommend achieving appropriate TBR goals and then assessing TIR. That's what a good endocrinologist should do. Now a goal of above 50% is appropriate in the elderly and the high-risk patients to avoid hypoglycemia and medication-related complications. Now a TIR of 70% corresponds to an A1C of 7%, and a TIR of 50% corresponds to, if I remember well, an A1C of 8%, which provides complementary data. Now for every 10% TIR increase or decrease, estimated A1C also increases or decreases by approximately 0.5%. That would be useful if you are monitoring your diabetic patients in the clinic over time. Let's move to the next slide, please. The question reads, Mrs. J.N.K., a 76-year-old female, is brought to your A&E with a decreased level of consciousness, and her spouse expresses concerns that she may not have been taking her home medications appropriately. Compliance issues. Her past medical history and past surgical history includes Alzheimer's, dementia, which could be the reason for her non-compliance, type 2 diabetes mellitus, thyroid, medullary cancer, status post total thyroidectomy, which was done 14 days ago. She currently administers 20 units of insulin degludec subcutaneously once daily in the evening. Apart from that, she takes 1,000 milligrams of metformin after breakfast and after dinner. And for her Alzheimer's disease, she takes 10 milligrams of donepezil once daily. She also takes 100 micrograms of levothyroxine as supplementary therapy after the surgery. And in addition to that, she supplements with a fixed dose combination of calcium co-formulated with vitamin D. Her pertinent labs include sodium of 130, potassium of 4.9, chloride of 105, bicarb of 24, BUN of 20, serum creatinine of 2.1, glucose of 80 milligrams per deciliter, calcium levels are 7.9, albumin is 3.2, WBC of 5.4, TSH of 45 million units per liter, free T4 of 0.06 nanograms per deciliter, and random cortisol levels are 5 micrograms per deciliter. The parathyroid hormone is 30 picograms per ml. Some of the vitals include a systolic blood pressure of 95, diastolic 65, with a heart rate of 59. The body temperature is 93.6 degrees Fahrenheit. So my question to you is, which of the following would you initiate in J and K's management? Would you administer 1 milligram of glucagon intramuscularly, start and then repeat every 15 minutes PRN if there is hypoglycemia? Or would you administer 100 milligrams of hydrocortisone intravenously thrice daily alongside 300 micrograms of levothyroxine IV? Or would you administer 500 micrograms of propylthiouracil once alongside 2 milligrams of dexamethasone injection IV every 6 hours? Or would you administer parathyroid hormone at a dose of 50 micrograms subcutaneously once a day alongside 200 micrograms of levothyroxine IV? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for hydrocortisone, 100 milligrams TDS alongside levothyroxine at a dose of 300 micrograms IV. Now, J and K's lab results are significant for hypothyroidism. Remember, she has a high TSH and a low T3 and free T4. And the adrenal insufficiency is also evident. Remember, the random cortisol is low. Now, J and K's signs and symptoms of decreased level of consciousness, the hypothermia, the bradycardia, are all suggestive of what we call myxedema coma. Now, a potential explanation for her presentation is non-compliance with the thyroid replacement therapy, the levothyroxine to be specific, which is required after a total thyroidectomy, which was done like I think 15 days ago, if I remember well. Now, her blood sugar levels aren't low enough to warrant treatment. I would not administer glucagon at this stage. That makes answer A wrong. And she has hypothyroidism, and administration of propylthiouracil would further worsen her condition by blocking the synthesis of new thyroid hormone. So I would not opt for C. Now, while this patient needs thyroid replacement therapy, the parathyroid levels are normal, so I would not opt for D either. Remember, the American Thyroid Association strongly recommends that the administration of IV levothyroxine and IV glucocorticoids when managing a myxedema coma case. So that would make alternative B a strong candidate, the most appropriate solution. Now, patients with this myxedema coma have a concurrent adrenal insufficiency, and therefore the glucocorticoid hydrocortisone would be recommended until the adrenal insufficiency can be ruled out. So I would automatically administer it until such a moment when I rule out the fact that there is or there is no adrenal insufficiency. Now, the typical regimen used in practice in most hospitals across the globe is the hydrocortisone 100 milligrams IV TDS or 50 milligrams IV QID. Now, levothyroxine, just for your information, has a long half-life of approximately 7 days. So if the patient were euthyroid on chronic replacement therapy and is made nil per oral, for one reason or another with an anticipated NPO status of less than 7 days, then it isn't necessary at all to administer IV levothyroxine replacement therapy in such a patient. That's just by the way to help you make rational decisions when you're managing such patients in the inpatient setting. So ladies and gentlemen, that brings us to the end of part 38 of our pharmacotherapy MCQ series. I would like to thank you sincerely, my esteemed viewers and listeners, for making time to view and to listen to this video. Now, if it helped you in any way, I would like to encourage you to give it a thumbs up, to like it, and if you haven't yet done so, I would like to urge you humbly to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I would like to say that I'm very thankful for your support and your kind collaboration. I look forward to interacting with you in part 39 of our series. Thank you very much for always being there for me.